All right, Anita, you want to welcome everybody from DSANV?
Welcome to our panel to discuss the Inspire treatment for sleep apnea. We're delighted to have Barbara and Katie and Anna, and maybe a guest appearance from Lily. No. Well, thank you so much for joining us. We are looking to put on more topics like this that are of interest to our members. During this, pandemic, we pivoted and we're getting better at doing things online. So we're delighted to have this format. We can bring so many people together, and we're delighted to have Dr. Baldessari, am I butchering that, with us, and Adam Wimmer to talk to us about the Inspire treatment for sleep apnea.
I guess I'll go first. Does that sound reasonable?
Well, let's see. Let's get Katie. Katie, why don't you introduce yourself?
Hi, I'm Katie Ramchan, and I'm a DSANV member, and I'm also the mom of a now 13-year-old Lily. Lily got the Inspire implant through the clinical trial in October in 2019. So she had just turned 12 at the time. And so we've made it through the full year of the trial that I'm sure Dr. B will explain more in detail. But what kind of sent us down that path was we had tried multiple different BiPAPs and masks and high flow and tonsils and adenoids over the years, and just nothing was really working and nothing was sustainable. And so she did qualify for the implant, and being 11 at the time, at that point, I think she was one of the youngest to have received the implant. There are, I think, some that are a little younger than her having received it now as well. But so that's kind of the perspective I'll bring to it in terms of a child at the younger end of the age range for the implant so far. But it's been a wonderful experience, life-changing.
Yeah, and I'm Barbara Hoops. I'm also a member of DSANV here in Northern Virginia. And this is my daughter, Anna, and she's 20 now. I first heard about the Inspire device and the clinical trial that was going on with Dr. Hartnick in Boston on a podcast. He was on with Dr. Brian Scottco, and I happened to be somewhere in the car listening to the podcast and was so excited about this possibility because Anna had been on a CPAP and then a BiPAP and multiple sleep studies and multiple changes of settings and all of that, and it just wasn't something that we felt. For us, part of the puzzle was that as Anna gets older, we would like her to be more independent. And the CPAP and the BiPAP experience was such that she always needed someone to help her manage it. And that was putting it on, taking it off. So she could do that okay, but cleaning it and then having to take it places on trips and all of that was really not something that we wanted to have her for a lifetime having to do that. So I emailed Dr. Hartnick and got the information from him. And then that was in 2018, in the spring of 2018. And then by that fall, we were down seeing Dr. Baldessari in Norfolk at the Children's Hospital down there. And there was a little bit of insurance mess, which we'll talk about, I think. But shortly thereafter, our journey started with some sleep studies and the discovery that Anna had lingual tonsils that were fairly large on the back of her tongue, and we had to get those removed. And that, so finally her device was implanted. I believe it was March in, is that right? I can't even remember, Dr. B. It's been in there a year now. We've just finished our last year sleep study. So I think it was March of 2020. Yes, it was, because it was right when the world shut down. We were on our way back up from Norfolk. We were driving and everything got canceled. So anyway, so that's our story, and we can talk more later about details if anyone has any questions. We have two guests with us today that we'd like to recognize. Adam Wimmer is the Territory Manager for Inspire Medical Systems for Central and Eastern Virginia. And Inspire, as you know, is a medical technology company focused on the development and commercialization of innovative and minimally invasive solutions for patients with obstructive sleep apnea. Adam has extensive experience in the medical device industry and has a degree in business management from UNC Charlotte. Also with us is a surgeon who did Anna's surgery from CHKD, the Children's Hospital of the King's Daughters in Norfolk. This is Dr. Christina Baldassari. She's an associate professor in the pediatric otolaryngology department there. She studied at Albany Medical College, Children's National Medical Center, and the VCU School of Medicine. Dr. Baldassari is involved in several professional societies, including the American Academy of Otolaryngology, Head and Neck Surgery, and the American Academy of Pediatrics. And she has lectured on the topic of pediatric sleep apnea, both regionally and nationally. She's board certified in otolaryngology and sleep medicine, and is the recipient of numerous grants to support her research focused on improving the care of children with sleep apnea. Dr. Baldassari lives in Virginia Beach with her husband and her 3 children. She's been recognized as a top doc in Coastal Virginia Magazine for several years, and we know why, because she's fabulous. So I'd like to turn it over to Dr. Baldassari, who will share a presentation and go over some basics, and then in a little while we will open it up for questions from the participants. If anyone has a question that you'd like to go ahead and get typed into the chat, you can do that while you're listening, and then we'll take those chats or take those questions when we're finished. So take it away, Dr. B.
Excellent. Well, thank you. That was such a nice introduction. But yeah, I'm really excited to be here. I'm going to share my screen while I'm talking, just to share a little bit of information. And I'm going to, okay. Can everyone see my screen? Can you see my screen okay, Anna? Okay, good. So I just wanted to give a little bit of update, and I'm going to try to keep it to under 20 minutes because I do want to hear everybody else's perspective. I think Anna has a great perspective on this, and so I'm going to go a little quickly through, but I'm happy to share my slides as well if anyone is interested in afterwards in having another look at the information. So in terms of sleep apnea, many of you may be familiar. Basically, it's just a blockage of the upper airway that occurs during sleep, and it can cause oxygen desaturation. It is more common in children with Down syndrome because they do have smaller airways and they have a lot of often enlarged lymphoid tissues such as tonsils and adenoids. And in terms of symptoms for obstructive sleep apnea, it can cause snoring, it can cause poor sleep. And some of the research that I had done several years ago really shows that even more importantly is that it have a significant impact on our children's quality of life. So these children can have behavioral problems, they can have poor school performance, and problems even with hyperactivity when you look at children that have sleep apnea versus those that don't. And so it is significant. And we usually diagnose it through sleep studies. Many of you may have had your children go through the sleep studies, but there's a lot of different leads. We measure a lot of different parameters, but the main thing that we're looking at is something called the apnea-hypopnea index, and that's basically your sleep apnea score, and it tells us how bad your sleep apnea is. So in terms of treatment, typically the first thing we do is remove tonsils and adenoids in kids that have sleep apnea, and we do know that that helps improve their sleep apnea score and improve their overall quality of life. But we also know that children with Down syndrome can have significant sleep apnea after their tonsils and adenoids are removed. And so what are your options? And this is a very busy slide, but traditionally there's been some surgical options. Anna did have the lingual tonsillectomy like we talked about, but you can get the tonsils on the back of your tongue after your regular tonsils are removed. That's a common thing that we'll do. The CPAP or BiPAP is another common treatment, but in many of these cases, you can still have persistent sleep apnea. This is just a picture of the lingual tonsil, which is, again, commonly done in kids that have persistent sleep apnea. Now, before Inspire came out, though, we didn't have a lot of options, as one of the other speakers was mentioning. Many of our children really struggled, and we didn't have any good options. And so when the hypoglossal neurostimulator came out, we were very excited about it in the surgical community. So this device is actually approved for adults. It's been approved now for about 7 years. And recently, It's actually approved now, and Adam can comment later. They just changed the indication down to 18. It was, I think, 21 or 22 in the past, but now it is FDA approved for patients 18 years of age and older, which again is a change. But basically the device is surgically implanted in the chest wall, and you can see a picture of it here. And then it has one lead that goes down and senses when you breathe in, and those kind of go between the chest wall muscles. And then the other lead goes up and goes around the nerve that is involved in helping to stick out the tongue. And previously, and this has been a little bit of a change, Anna can speak to this, in adults we were doing 3 incisions, and so for Anna, she can attest to the fact that we were doing 3 incisions before, but then in younger children that were implanted with Down syndrome, we were doing 2 incisions. But now in adults, just in the past maybe 3 months, we're now going to move to doing 2 incisions in adults as well. So just 1 in the neck and then 1 in the upper chest. And so that's been a very recent change. This is just a picture of the cuff itself. This is one of the little leads, and that's a picture of it going around the hypoglossal nerve. And basically it just sends a little stimulus, and you can see here on this picture when it sends the stimulus, it makes the tongue stick out. And so in sleep apnea, what is really a problem is a lot of times your tongue falls back and it blocks your airway. So this device, when it's turned on at night when you're asleep, helps stick your tongue out, or at least fire the muscles that partially stick your tongue out so that you can breathe better. And so, as we mentioned, there was an initial trial that both Anna and the other patient were involved with, and it started in Boston, and then first few patients were done there, and then they expanded it to 6 other sites. And we were lucky to be one of the sites. I think we were the only site maybe in the Southeast, but we were very excited to participate. And initially we were looking at children between 10 and 21 years of age that had sleep apnea. You had to have pretty severe sleep apnea with a score between 10 and 50. And you had to have tried CPAP and not been able to tolerate it, or for some other reason, wanted a different treatment. And then, it was very specific. When they were doing these criteria, they did, they had some children that were excluded just because they based it on patients in the adult world that had initially responded well. And so I do think some of these criteria may change with time, but this was kind of just a starting point for us. And so children that, had other severe medical conditions, so maybe bad heart disease that wasn't well controlled, we didn't implant them. We weren't implanting children that needed to have serial MRIs just because we worry the device is MRI compatible, but there could be artifact. And so you can still get an MRI, but if you were going to require multiple chest MRIs, we said this might not be the best treatment for you. But again, you can definitely get MRIs with it. And then the other main criteria that allows you not to, or excluded you from the study, was the pattern of collapse on your sleep endoscopy. And so basically for sleep endoscopy, for those of you who aren't familiar with it, this is a newer procedure in our sleep surgery world, but it's been it's really improved the care we can provide to our patients. Basically what we do is we take a tiny little telescope and we put our patients to sleep. We give them some sedation, and we basically give them the sedation until they start to snore. And then when they start snoring, we put our little scope in and we look at where the blockage is occurring. So where is it that their airway is being blocked? And as I mentioned, in children with Down syndrome, many times the back of their tongue falls back, which is why the Inspire device works so well. So this is a little video. There's 2, we can play both at the same time. The one on the left is showing what's called a good pattern of collapse, a pattern of collapse that the Inspire device will work on. It's more of this kind of kind of tongue falling back-ish. And then the one on the right, it's more of a funnel shape. You can see kind of, it looks like a funnel closing down. That funnel shape pattern does not work well for the device. It just doesn't, our outcomes aren't as good. And so we tend, if you have that funnel pattern, then we do not recommend the implant for you. So that's one of the exclusion criteria. And so anybody that's being considered for the trial, you do have to have that sleep endoscopy prior, but again, it's pretty short, maybe 10-minute procedure that's done prior. And then Anna can speak a little bit more about her post-operative experience, but typically we will turn on the implant about a month after the surgery, and then when we turn it on, we perform a sleep study that same night. And for the study, we did a fair number of sleep studies. In addition, we did one 2 months, 6 months, and then 12 months. And the reason is because when we first turn it on, we don't want to turn it on to too high of a degree, because we want our patients to kind of get used to the sensation. And so we kind of slowly over time turn it up until we notice that their sleep apnea has gone away. So I think this is a paper that was written about the very first child. Is a 14-year-old that had the implant placed up in Boston. And I really like this picture because this is a sleep study. I read a lot of sleep studies in my job. And so basically, this is a picture of what a sleep study looks like. I said we record all these different leads, and so this is what you see when you're looking at the sleep study. But you can see all of these little kind of, on the left, this was before the device was turned on, and you can see all these kind of black spiky things. Every time there's a black spiky thing, the child's airway is closing down and they're not breathing and their oxygen is dropping. But then when you turn the implant on, you can see it just completely disappears, just like that, just with one kind of touch of the device. So it was just very impressive how, how effective, the device can be. So I really love that picture from that first study. So now we just finished up the initial study. Initially, we had hoped to get 50 patients between all the different sites, but COVID happened, and as you know, it changed a lot of things. But we were able to have 33 patients total that participated, and right now, so far, we have information about the first 20 patients for a year. And what we found that it was in 18 of the 20 children that we have the 1-year data on, they had some improvement in their sleep apnea score. And really 75% of these patients had what we would consider non-severe disease. So ideally you'd love a score less than 5, but really less than 10 is acceptable and is from a cardiovascular standpoint and from all those other risk factors we worry about. A score less than 10 means that you're at a very low risk for any of those things. And so most patients, if your score is less than 10, they feel much better and they're sleeping better. And so pretty impressive that, 3/4 of our patients were able to get those scores less than 10. And so we're very excited about the results. And what was even more exciting is that we saw the caregivers and children themselves really reported that there was significant improvements in how they felt in terms of their sleepiness. That's what the Epworth score is, and in terms of their quality of life. And what we heard from a lot of parents, especially of younger kids, was that they noticed improvements in language and sometimes in cognition, so that they felt like their kids were, had a huge kind of burst of new language after they were sleeping better with these implants. And so that led us to think, well, could we look at that? And so there is a new study that is just starting. Again, Mass Ioneer is sponsoring this study, but we're lucky enough to be participating. Again, I think there's 6 sites across the country, and the inclusion criteria are the same as the first study that we were doing. So 10 to 21 years of age. And for this study, we're still looking at sleep study results, but we're also going to pay more attention to language and cognition. So we're having the children give us some language samples and also do some neurocognitive tests just to look at how they do before and after and see really what kind of results we're getting, because obviously that's important to families. It's great if your score gets better, but what's more exciting is if, your children have more language and are able, to feel better in school and perform better in school. And so we are very, very excited about this trial. So if anybody is interested, I'll leave my email there, or I can also provide it in the chat as well. You can reach out to me and I'd be happy to discuss more with you about the trial. In terms of the next thing, I think for the future and what we're really looking forward to is FDA approval. As I mentioned, currently the device is not FDA approved for children with Down syndrome. Really, it's only available through the study, but we're hoping that with the initial data, the FDA will at some point consider, since it was very safe and efficacious, the complication rates were very low. There were just a few patients that had some minor infections, and there was, but nothing that was concerning at all. And so we're hoping that at some point the FDA will increase the age range down to 10 or 12, because one of the things about the FDA approval, and Anna's family will speak to this, is that, you know, insurance can be very difficult, and it can be very hard to get insurance companies to do this. As physicians, you know, we try to be your advocate, and you know, many of you have been great advocates as well, calling insurers and, you know, sending letters, and so I think as we get more data, hopefully they'll listen, and we'll be able to get more of these devices covered. But I think that's going to be the next hurdle, hopefully, is getting insurance to kind of to cover it so that we can offer it to more patients as we get more and more data about the efficacy and how well it works. And that's all I have. All right. Okay.
Barbara, I think you're muted if you were addressing the group.
Yes, I thought I just unmuted myself.
Probably.
Sorry about that. Thank you. So the question in the chat says, do you expect the device to eventually be approved for those with sleep scores of less than 10 in the future?
Dr. B, I think you're all.
Yeah, there we go.
Yes, yeah. After all the Zoom meetings, you think that I could unmute, but no. So, I think so. I mean, initially, because we were just making sure that the device was safe and efficacious, we were focused on kids that had more severe disease. But I think in the future, if we continue to see such great results, we will offer implantation to children that have more milder forms of disease that are symptomatic, meaning they're not sleeping well, you know, they still are having trouble with either focus or behavior because of their poor sleep and their snoring. So I do think that will come, but probably, you know, it's still probably a few years out, because the focus still right now is, you know, getting FDA approval for, you know, the more severe disease. But I do think as we get more data, it will happen.
So the insurance challenge, I'm sure Katie can speak to this as well, but of course at the beginning, the insurance company denied everything. And then we had to challenge that. And I will say that the Inspire company and the folks that work there were incredibly helpful in pulling together the paperwork that was necessary to get the insurance company to approve it. So that was, it was a little bit of a runaround, but it eventually was successful. Adam, is there anything you want to add from the Inspire side of the house?
Yeah, while we're on the insurance topic, just for, it was very challenging in the past. And it is getting better and better as time moves forward. For example, I've been with the company approximately 2.5 years. When I started, we had one insurance carrier, which was United, that would have a coverage policy to automatically approve an Inspire implant. Now we have everything from an insurance company except for one provider, and that is Anthem. Unfortunately, they don't have a coverage policy. However, they are still approving these on a case-by-case basis. It takes forever, which is exactly what you experienced and many others. So the good news is it's getting better, but it does take some time in many cases.
Mm-hmm. All right. So Anna was interested in joining us on the webinar today because she's actually a global messenger for Special Olympics. So she has had some training in public speaking and enjoys speaking to groups. So she's happy to be here. And she can tell you a little bit about her experience, about how she feels with the device and what, you know, the independence that it gives her. But also she is willing to fire it up and show you how it works if you're interested. I told her that I wanted her to just lean her head back here just a little bit, and you can see the very small scar. You probably can't even see it. That's the one underneath her chin here. And then she also has a scar in the mid-rib cage and then in the lower rib cage, as Dr. Baldessari was describing. So Anna, do you want to tell them about your experience?
It was fun.
so tell them.
Sorry.
So the surgeries, were they okay? Not too bad?
Not too bad. Just when they hooked the wires up to me for the sleep studies, sometimes it would hurt, but I got used to it.
Yeah, that's a little bit annoying to get all hooked up for the sleep studies. But when you go to bed at night and you turn it on, does it bother you?
No.
No? And you can sleep well with it?
Yes.
You feel like you get really good sleep?
Yes.
Yeah.
And in the morning after I wake up and turn off my device, I'm more friendly to my parents.
Yes, she is more rested. So, so do you want to show everybody how it works? So this is the device. It's about the size of a computer mouse, and it has a white light on that indicates that it is charged and ready. And then when you turn it on, it's a green light that's around it, meaning that it's going. And then, so you want to show them how it works, and I'll sort of narrate. So that's the play button, more or less. So she turns it on, and it flashes green. Oops, it stopped flashing green. Hang on. There we go. Try it. And it's over here on this side. There we go. And see if it can. It's not doing it. It had trouble last night too. We may have to change batteries. Come on. Now, Dr. B, we're going to be embarrassed here. Try it one more time. But it doesn't seem to indicate that it has a battery problem, but it doesn't want to. It should turn solid green.
Yeah,
Nope.
Barbara, give it. You've hit the button a couple times. Hit it one time. Give it 10 seconds tops. And
Okay.
let it cycle.
There it is. Is that on now? Okay, yeah. So you can see that this glows solid green. Thank you. And so what it does is it gives her tongue a little tweak to just let her know that it's on, but then it rests until I think it's maybe 20 minutes, Adam, is that right? Something, 10 minutes, something. It's a short amount of time so that then the child is asleep, and then it operates, and then you can turn it off. You hit the off button and then hold it over. Just hold it there. There, and it turns back white again. So it's very easy. Last night was the first time she'd ever had any trouble finding it and letting it turn on. So I don't know what was going on.
It took me a very long time.
Yeah, but it works reliably for her every night. She's very independent. She she'll be a junior counselor at a Girl Scout camp this summer, and
That's actually my job. I'm actually going to be paid.
Yeah, I know. She's very excited. So she'll be able to take it with her, which is something that she wasn't able to do with a PAP machine because there's no power at a Girl Scout camp. We'll just send a lot of batteries. So Katie, do you want to talk about your daughter's experience?
Yeah, our experience very, very similar. Lily had very, very little postoperative pain. She did not have the lingual tonsillectomy, so her only surgery with this was the implantation. I'd say her scars a little more pronounced. I think she probably was more prone to keloid scarring, and that's something that we would kind of keep in mind if she needed to have anything else done, but it'll go down over time, and it's still not particularly noticeable. That's really, if that's the extent of a complication, for something that fundamentally changes how she sleeps and is healthy, it's definitely worth that little slightly more visible scar there. The biggest, she was not in pain. We did go up to Boston. I think when we started the process, Norfolk hadn't come online yet, and so we were in a hotel, and we were going out to a restaurant that night. She did an overnight, the surgery, you stay overnight with the trial. I correct me if I'm wrong, but for adults, it's an outpatient procedure. You don't stay overnight. But she stayed overnight. She was discharged the next day. We watched a rerun of the Nationals World Series game, and then went out to Italian in the North End. So she was really not in pain. The most significant thing, she's a very active kid, and she did not like the sling. She was not a big fan of having her arm restrained for a couple weeks, and we also were on the more conservative side, and kept her more restrained for closer to a month. But it's a soft sling. That was more, she was irritated by it than any sort of pain. And then she's had, she's been entirely compliant with it. She tells us if we forget to turn it on. Most of the time she turns it on herself. You know, we have a few times where we can't find it as well, but it always connects ultimately. And, you know, I think we've seen her in terms of the cognition and language changes. That is something that we observed with her pretty quickly. She never had any, she was never a child that exhibited tiredness from sleep apnea. You know, I think some children actually present as more hyperactive when they're tired than actually seem tired. And I think that's more her characteristics. And so it was, you know, the best, what we were able to kind of see in terms of change in her behavior was better behavior, and really a pretty noticeable change in her expressive communication. That was the first thing we noticed. We were noticing pretty significant, or I'd say more frequent novel vocabulary use, where we would kind of look at each other and think that's a word she hasn't used before. That was far more frequent, and also more kind of being observant and expressive about what she was seeing. So driving in the car and commenting on something out the window, things like that. You know, she did have the surgery in October of 19, so she was not, I think, fully at a therapeutic level before the pandemic hit, and so our titration schedule got a little bit shifted, and I think we probably her, you know, the gains that would likely have been determined in terms of the pre and post surgery neurocognitive testing may not have been as pronounced, just due to all of the factors that we've all experienced with the pandemic, with the isolation and the lack of school and things like that. But I pulled it up. You know, Lily did participate in the testing before, baseline testing before the implant, and then the testing afterwards. And we don't have the hard data, but they did give us the kind of general areas of improvement. And the areas that they assessed showed improvement were intelligence, working memory, attention, verbal fluency, receptive vocabulary, and memory. And then also the parental responses showed improvements in behavior and social and communication skills. And just from a kind of day-to-day practical standpoint, she started sleeping through the night for the first time in 12, 13 years, which has an impact on the entire household. So that, I think, is, you really can't overstate kind of the impact on the household as a whole, when I kind of said earlier that it was truly life-changing for us. So Lily's, she does, I think her final numbers, she did have one study that got her down to 0 apnea. I think her last one was at a 4. You know, I think it can vary a little bit study to study, but she is well under the severe range. And like Dr. B mentioned, anything, you know, less than 10 is good. Anything less than 5 is great. So we're very happy that we pursued this. I'll stop.
All right, so let's go to some of the questions that have been put into the chat. Does the device have a lifetime? Does it need to be replaced every so many years? Adam or Dr. Baldessari?
Sure. The actual implanted device lasts approximately 11 years before requiring replacement. And yes, it will require a second surgery, but very quickly, the battery is replaced, not the entire device. So it's a relatively quick and easy change out. The sleep remote that Anna was showing everyone, that runs on 2 AAA batteries, and those last approximately 2 months, depending on how much you're using it.
Mm-hmm. Yep. Does the device have to be right next to the patient at night? And I know in our case, it just lives on the nightstand, right? It lives on the nightstand, but I don't know the limits of that. Adam, again, do you know?
Yeah, great question. Once the device is turned on, you can be free and away from your sleep remote. Most are not because they are sleeping, right? And so you use that remote by your bedside. But yes, there is not a range limit.
Right, but with a child who you would want to have more control over it, the device you can remove from the room once they're asleep.
Absolutely.
Okay. Anna, if you wake up during the night, what does it feel like?
Oh, that's hard.
Well, do you feel your tongue moving?
Yes.
Mm-hmm. Does it bother you?
Only a little bit, not a whole lot.
Okay. I know the dog is here, wants to be part of the conversation. So if you wake up during the night, do you fall back to sleep again pretty easily?
I try to.
Yeah, it's I'm sure Katie could talk about, oh, there's Lily, could talk about this as well, but it moves the tongue. That's literally what it does, is it moves the base of the tongue so that it doesn't block the airway. So you do notice from the outside some movement of the tongue, but it's just in the, when the device is on, but it's not intrusive or overt in any way.
Yeah, I was going to say I sleep on my side when I turn on my device.
Anna was one who had very, very high AHI numbers. I don't know if Dr. Baldessari remembers, but she was so high that she didn't qualify for the study at first. The study is between 10 and 50, and Anna's numbers were about 80. It was a shock to us how high they were. And the lingual... Hi, Lily. How are you?
Do you like your Inspire implant?
Do you have one of these?
Yeah, see?
Just like that, right?
Helps you sleep better?
Yeah.
All right.
Yeah.
That's it.
So,
shocking, okay?
So the lingual tonsillectomy allowed or brought Anna's numbers down into below 50 so that she would qualify for the study. We didn't know if she would qualify for the study until we did that. So that was something that, as Dr. Baldessari was describing, there's sort of a process of treatment, and that was one of our steps. How is the internal device powered? That's a question. Adam?
You were going to be surprised, but I've never had that asked. The actual type of battery that it
Okay.
is beyond me, and I actually am going to find that out and report back. I'm not sure if it's a lithium type of battery, but something that holds a charge for 11 years and allows us to power that at a very small voltage, right? Your 9-volt battery is almost twice as strong as our maximum setting for Inspire. Most folks are on 1 to 2 volts as a maximum. So that's a great question, and I will find out exactly what type of battery it is.
All right. The lingual tonsillectomy, a question in the chat says, is this present in every person, or is there extra growth that sometimes needs to be removed? Dr. Baldessari, you can probably address that.
Yeah, so no, lingual tonsils are not present in everyone. So your regular tonsils, we call the ones in the back of your throat, those are called palatine tonsils, but those are, everybody does have regular in the back of the mouth tonsils, okay? But there are a small number of people that do develop enlarged tonsils on the back of their tongue, and we don't really know why, but we do know that it is very common in children with Down syndrome to have enlarged lingual tonsils. And so it is one of the most common surgeries that we perform in kids that have sleep apnea after they've had their regular tonsils removed. We don't know if it's in response to, removing their regular tonsils, but there are plenty of kids who get the regular tonsils removed and don't have that kind of vigorous response. So we really don't know why they happen, but we do know it is common in children with Down syndrome, but not every child with Down syndrome has that.
Sounds like a research study coming. So the question comes, I'm an academic. I think of that in that way, the same way that Dr. B does. All right, is this a better solution than a BiPAP for reasons other than independence and convenience? Is it a better treatment than the BiPAP? And what are the lingual and cognitive changes attributed to better sleep or something else related to the device. So let's talk about the efficacy of the solution compared to the PAP machines.
So I think that it depends on the child. And so if your child has complete resolution of their sleep apnea with their BiPAP or CPAP, meaning, their score is less than 5, and then I think that they're equally efficacious. If also your child is wearing the device for 7 to 8 hours a night, then I would say they're equally efficacious. But, in many of our patients, they're not able to, if they can wear the device, it's often a shorter time. And in some patients, we have trouble getting the AHI down with even a BiPAP, they're still elevated. And so I think it's very dependent. But if your child is wearing the device 7 to 8 hours per night, and the sleep studies have reliably shown a score less than 5, I think that they're very similar in terms of sleep apnea kind of cure rate outside of the, the independence that you mentioned.
Mm-hmm. All right. So also in the chat, there's someone whose child sleeps all over the room and won't tolerate the mask. So that's the difficulty. So this is this is a choice that they've decided to pursue for those reasons. And then Jesse, did you feel like your question was answered in terms of comparing the device to the successful BiPAP solution, or is there anything else you'd like to add there? Feel free to unmute and ask us.
Sorry about that. Yeah, we're lucky. My daughter's very, very good with her machine. So that's why I was trying to compare whether or not it was, like a better solution. I certainly think it's probably better, more reliable, of course. I can't control whether or not she takes her mask off during the middle of the night, but obviously the device is always with her, and so it would never stop working. Mm-hmm. So for that perspective, I'm sure it's better. I just didn't know if there was a reason to go that route if what you were using had been successful, and the doctor kind of answered that as well. But another question too is, have you ever had a patient who did have the device implanted where the success rate was such that they still did have to wear a BiPAP? Like it didn't, have you ever had one that didn't fix it well enough to not have to do anything else?
No, not yet. So that's the good news. There's there's a lot of different things that you can do if the device isn't quite as successful as you want it to be. You can change some configurations. There's a bunch of different things that you can do. But I think that the reason that we have not had a lot of failures is because we are pretty strict about the children that are implanted. So again, you have to meet those criteria. You have to have a certain, we're not still implanting kids that have really, really severe disease. We're also not implanting children that have significant obesity because we worry they might be higher failure. And so we haven't seen that, but I think it's because we're so strict about the children that we are implanting. So we have a pretty high success rate.
There are a couple of questions in the chat regarding the lingual tonsils and whether or not they're visible to an ENT just on a standard examination, and if you've already had a tonsillectomy and adenoidectomy, would we have been told? In our case, I'll let Dr. Baldessari respond, but in our instance, we were completely surprised by this at the age of 18 that she had this overgrowth of lingual tonsils. She'd seen an ENT her entire life. She'd had lots of sleep studies. She had a tonsillectomy and an adenoidectomy, and we had no idea that it was there. And as Dr. Baldessari mentioned, they can regrow, or they can, once the palatine tonsils are out, right, then the lingual tonsils can grow. That's kind of the sort of the way that it happens sometimes. So it was a surprise to us, and that was something that we didn't realize was affecting her her sleep quality as much as it was, given that she'd been a CPAP and a BiPAP user for years, and it still was a factor. So Dr. Baldessari, do you want to address that?
Yeah, so I think, interestingly, sleep surgery, especially in kids, is still a relatively young kind of field, really. And so we've really found out more and more about lingual tonsils when we started doing the sleep endoscopy that I mentioned, because that's how we found Anna's, is we went to look to see if she had the evil funnel shape that doesn't respond well to Inspire. And I said, oh my goodness, she has huge lingual tonsils. this is definitely a problem, or it could be a source of obstruction. And so I just think many ENTs aren't, I'm a super specialist, so I do just mostly pediatric sleep apnea, but many ENTs, are still kind of, this is just a new emerging field. And so some of the ENTs may not be aware, but usually now if you have a sleep endoscopy, you cannot see the lingual tonsil with the naked eye. You need a telescope because it's on the very back of the tongue. And so most commonly we'll find it during the sleep endoscopy. So if your child has persistent sleep apnea after their tonsils and adenoids have been out and they can't tolerate the CPAP, then that's when I usually do a sleep endoscopy. And so if your ENT in your area doesn't do it, then there may be a specialist, at a children's hospital around that might be able to do that. But that's when you should consider looking for the lingual tonsil enlargement, is if you've already had your regular tonsils out.
Okay, there's a question in the chat about the risks and the consideration factors or hopeful long-term benefits in individuals with congenital heart diagnoses. I know that would not qualify for them for the study, but what do you think about that for future long-term?
So in kids that have congenital heart disease that's well controlled, meaning they don't have significant heart failure, then we can implant them. They can be part of the study as long as their heart disease is well controlled. But certainly we do know that children that have congenital heart disease, their sleep apnea can make congenital heart disease worse. And so I think if we are able to implant those kids long term, I think their heart outcomes may be better. And so if we can control their heart disease well enough that we can get them to qualify for the implant, meaning they're medically stable enough to undergo, then I would be an advocate for the implant, because I think it would improve their overall health long term.
I'll just chime in. Lily, my daughter, was born with AV canal defect, and it was fully repaired, so that did not exclude her from participating in the trial. So I know that a lot of children with Down syndrome have repaired heart conditions, and so I think that's what you're talking to in terms of it being, as long as it's controlled and repaired, it's not necessarily an exclusion.
So there's a comment and a question in the chat about busy sleepers, a son who has problems sleeping through the night, gets out of bed. Did any of your kids have trouble sleeping through the night before they were diagnosed with sleep apnea? And I think the answer is yes. I think what sleep apnea does, if you're not being treated for it, is it rises you to wakefulness. It was described to us as somebody sort of bumping you on the shoulder, and sort of bringing you to wakefulness every time your body is trying to breathe. And, if Anna's being sort of poked 50 times in an hour, right? She's not going to sleep very well. And so I think when a child is being brought up to wakefulness on a regular basis, then it will cause that busyness. I'm not an expert, and of course Dr. Baldessari has a lot more experience, but our experience is that there's a big restlessness that happens with especially untreated sleep apnea, because there is this the body is constantly trying to bring you back to wakefulness to get a full breath. Dr. B, that was the layman's explanation.
You couldn't have said it better. I mean, 100%. I mean, yes, your body, every time you're having an event where your airway's blocking up, your body is waking itself up a little bit, to try to open the airway to breathe. And so kids that have sleep apnea that's untreated, they are restless, they wake up all the time. And it's always amazing to me. Parents will come back in, and just like our other speaker said, they will say after their surgery, when their child's sleep apnea is cured, this is the first time my child ever slept through the night, in their whole life. Thank you so much. And so I hear that a lot. So I think that treating sleep apnea really does make a big difference in terms of your busy sleeper and your kids that wake up. We see a significant decrease in those awakenings if we can treat the sleep apnea.
Thank you. So then there's a question about the difference between the AHI and the obstructive apnea hypopnea index. I don't know if that's.
So Yeah, so that's a good question. So there's two types of sleep apnea. I talked mostly about the obstructive type. So that's the type where the airway kind of closes down on itself and blocks it. But there is a separate type of sleep apnea called the central. And so that's where your brain kind of forgets to tell the body to breathe. And most kids in general, and kids with Down syndrome do have obstructive sleep apnea. But as one of the criteria for being a candidate for the device, it has to be your obstructive apnea-hypopnea index, not your central, because if you had a high central apnea index, the device wouldn't be as effective because it's not going to tell your brain to breathe. It's just going to open up your airway when you're trying to breathe. And so indeed, it is the obstructive AHI that we're basing the criteria on to get into the study or to have the implant.
All right, I think I got everything unique out of the chat. So are there any other questions that we can answer? Or Katie, did you have a comment?
I think there was one question about if the source of the improved cognition and speech is known. And I don't know, but I'll just say from our experience, I know that it seemed like the words were just coming to Lily more easily. And I know personally when I am very, very tired, I have to kind of think about which words I'm looking for. It just takes a little bit longer to retrieve that word that you're thinking of. I had a really bad night's sleep last night. So if I'm a little bit, less than articulate right now, that could be why. But so that's my mom theory. And that, it's the sleep that is fundamentally, it's really the processes that happen in the brain with sleep in terms of, I think that's where I'm going to not get in beyond my depth with medical terminology, but I know that there is a lot that actually does happen in the brain with proper sleep, and those processes are disrupted with wakefulness. And so that's kind of what it seemed like to us. It was just things, the processing was smoother when she was less tired.
Thank you. There's a question about whether the device is detectable in a magnetometer or pose any issues for flying. Adam, do you want to address that?
Flying is not an issue. We have many pilots that have the Inspire device.
Going through how about going in the airport, going through the...
It's going to go off, and every patient will have an implant card, much like you would for a total hip or knee. And it will, something that you can easily share with TSA that you have.
Yeah, Anna has a card. So if we ever have to send her through the sensors at the airport, she will have to show them the card. So,
and Lily has the same, and actually we've been through, because when we went up to Boston for our follow-ups right before the pandemic started, we flew both times. So she's flown up with it. And we just did, we used TSA Cares, I believe, just to smooth the security processing. But it was totally fine. I just said she has an implantable medical device. She's not supposed to go through I think it was either the X-ray or whichever ones were there. And they just did a pat down, and very simple, very easy. I think using TSA Cares is helpful. It does smooth things. And I'm happy to pull that information and provide it to DSANV to post along with this. But I also took that card and just put it in like a badge lanyard so that we had it with us. It was right there so that we weren't fumbling to pull out our medical device card if we were going through security. And so it's a picture. It's also got a picture of the X-ray. So if they really wanted to question, I have the image of the device itself, the chest X-ray. So that's kind of how we've handled it, but it's been very smooth every time.
I'll take those hints when we travel next. There's a question as to whether the device is visible above the skin. And in our instance, I think if it's not, you can't see anything, but I think if you were to feel right there, you might feel it a little bit. It feels kind of, does it feel hard in there? Right?
I know it feels soft.
Yeah. But I mean, if you touch it, can you feel where the device is?
I think.
Not very much. Let's
Not
put
very
it that way. So, yeah, no. So there isn't anything that's noticeable above the skin except for the small scars that are there.
Yeah.
And then the question came up: can we pursue this even if the child is successful with the BiPAP? Now, Anna was mostly compliant with the BiPAP. It wasn't curing anything, right? It just continued to, blow air in there to try to keep her asleep. She didn't like it, and so that was sort of how we approached this, was that it was a better solution. So Dr. Baldessari, what do you know about that compliance issue in terms of qualifying for the study?
Yeah, so I mean, the study, it's how you interpret BiPAP, intolerant, for me, I mean, right, your family's goals were for Anna to be independent. And I think that this is a surgery to improve, children's quality of life, right? And so for me, I interpreted that way, and the insurance, apparently agreed with us eventually. And so I think that, there's a lot of ways to define intolerant. And so in my, I think giving someone independence and freedom, and like you said, all the times that you can't wear the BiPAP or it falls off, those are all nights that, right, you're not getting adequate oxygen to the brain. And so I think that counts as intolerant from my standpoint. And so I would argue that if a family wants it to improve their child's, independence and to improve their, overall quality of life, then I think that counts as intolerant. So, but I'm a big quality of life outcomes research person. So that's my take on it.
Mm-hmm. And the follow-up question is, would a family or would an individual have to try a PAP machine first before being considered for the trial? Do you have to go that step?
Usually you do, or you at least have to have a CPAP titration study where the child just wouldn't even wear, something documenting saying the child wouldn't even because I have patients who won't even put the mask on their face at night during the titration study in a sleep lab. And so if you would at least have to have a sleep study that said, hey, we weren't even able to fit the child with a mask. They couldn't even wear it. And that would count. And so that would count as a trial if they weren't even be able to get the titration.
Thank you. Adam did enter into the chat that he found out that the battery for the device is a lithium battery. So that's information for anybody who needs that. So any other questions? We've reached 7:30, but we're happy to hang around for a few more minutes if there are other questions.
If you have any questions for me, let me know.
Anna's happy to answer questions. Possible problems with using the Inspire device. Adam, what do you have from an experience standpoint there?
Problems isn't the word I would use. I believe Dr. Baldessari's example of where we have so many different ways to program the device to reach the successful outcome that you and Lily have received. And 9 out of 10 patients, we can use 1 or 2 of these settings. And then some of these patients, we have to use different settings to achieve that outcome. So I wouldn't define it as a problem. I would simply state that there's just a little more tuning of the device to receive that outcome. And actually that's really it.
Okay.
Yeah, I can comment too.
Okay.
I can comment too. So when we looked at the study, because we were really focusing on safety during that first study, in addition to efficacy, but we really want to make sure. So there were 2 kids that had minor infections that just got antibiotics and they resolved. And there was one child that did actually they had some problems with central sleep apnea when their device was turned on initially. I think because their sleep apnea was so bad. And so that child, and that's why when we do the sleep study right after we turn it on, just in case. And so that child did require a little bit of oxygen for 2 or 3 weeks, but then their body acclimated to actually breathing, having such an open airway that then their central apneas went away. And sometimes, very rarely, you'll get central sleep apnea when you initially treat your obstructive sleep apnea. That can happen just because the way the brain is kind of reacting to the change in different CO2 gas levels and things. But that happened in one child as well. But that was really it. And one child had a little bit of an incision that broke down because they picked a lot at the incision. And so we tried to put all the stitches underneath to prevent that. But that was, out of all those 33 kids, that's all that those were the only complications we saw. So they were all very minor.
Mm-hmm. One more question about the CPAP usage in terms of qualifying for the study. How recently do you require the patient to have tried it? If a child is 8 and tried it and couldn't do it when they qualify at 10 and are eligible for the device, will they have to try the CPAP again, or is that enough history?
Yeah, I would not, if the child is not, if the family does not want to pursue that as a treatment option, then I would not make them repeat the CPAP trial unless they're interested in repeating it. But you do have to have, for this study, a sleep study. I believe this study is within a year, so a regular sleep study to make sure that your number is between those numbers. But even if you're, like in Anna's case, even if your number is not, we can still sometimes get you to the number that you need to get the device based on some other, procedures and stuff we can do. But you do need a recent sleep study, but not necessarily a recent CPAP titration.
Okay. And somebody asked Anna, what's your favorite part of having the device?
Well, oh my gosh. I'm trying to calm myself down from laughter.
Do you like the independence of it?
Yes, it actually helps me stay independent.
And what about wearing that mask with the hose attached to it and the noise of that? Is that something that you don't miss?
I don't like it as much,
Mm-hmm.
so I don't really miss it.
Yeah, so you don't like that. Anything else that you like about having the device? You feel like your sleep is better than when you used to have the PAP machine?
Yeah, my sleep is better, but I also feel like my behavior is much better.
Mm-hmm. By the time Anna had the implant done, she was 18 and practically done with high school. So there wasn't a lot of school related experience that we had in terms of her cognition levels or focus or anything like that. Now, she is in community college now and doing very well. She made the dean's list in the spring. So she's finished 2 years of community college now. We're super proud of her. So, I can't say that it's caused by having the Inspire device, but I certainly think that her ability to function in life is definitely enhanced by the good quality of sleep that she's getting. So that's all I can say there. So one more question about the ALF device. Have you heard anything about that successfully helping to treat sleep apnea in kids with Down syndrome? Is that something you're familiar with, Dr. Baldessari?
No, I need to know what what is the acronym? I mean, what is the abbreviation? Maybe they can type it in.
Get that paper. Can you hold on one sec?
I think
Sure.
it's a mouth device, I think.
Oh, okay. So yeah, there's a lot of different treatments for sleep apnea. So there is something called an oral appliance, so something that dentists make that basically it looks like a bite block kind of, but it brings your whole jaw forward and and then you sleep with the device in. In younger children, it's not a great option because obviously their faces are still growing and their teeth are still changing. I have had some success using it in older patients, but if your tongue really falls back, it can only bring it so far forward. And so I have had some patients respond, but if your tongue is really your primary site and you have really bad sleep apnea, it's not as effective. It's great for mild sleep apnea and snoring. That's really where we've seen it be more useful. But for severe sleep apnea, I haven't had too much success in getting the numbers where I'd like to be.
Yeah, I don't know anything about the use of we looked into the ALF device and I can't remember the details of it, but I think the low tone in Down syndrome that is usually the cause of the collapsing tongue is always going to still be low tone, right? You're not going to ever change the tone of that, the general muscle tone. So
Thank you.
But I don't know, Jesse. I'm sorry to not have more information about that. Okay, any other questions? This is so fun because it's really been a great journey for us, and we're happy to share it with anybody else who has questions about it. All right, so feel free to go ahead and drop off. We'll hang around for a few more minutes, and remember that the presentation is recorded, so if you need to go back and revisit it for any reason, DSANV will get it posted.
Thank you so much.